વેટ્સ તો આપણે ત્યાં રેગ્યુલરલી થાય છે ને?
હા. ના એમ નહીં, તમે આપણે ભણતા હતા ત્યારે એક વખત એની જોડે નતા આપણે?
હા, કાર્ડિયોથોરેસિક એક વર્ષ સુધી કરી છે.
એક વાર મેં કર્યું હતું તમે
ભટ્ટ સાહેબ જોડે કરેલું.
મોર દેન 200 લંગ રિસેક્શન્સ. મારું ડેઝર્ટેશન જ આના પર હતું, પેરીકાર્ડિયેક્ટમી ફોર
tuberculosis. એક વર્ષ હતા.
Yeah, 1 year.
Yeah, 1 year.
That's right. માઇટ્રલ સ્ટીનોસિસ માં ફિંગર રપ્ચર કરતા ને?
ક્રૂડ સર્જરી.
એ ટાઈમે એ જ હતું. એ ટાઈમે એ જ હતું, બીજું હતું જ નહીં કઈ.
That's right.
એ પણ થતું હતું એટલું કોને? એ સિવાય તો કશું નહોતું થતું.
Jagdish,
shall we start?
Yeah.
Okay.
So good morning to all. Welcome back to Saturday Club morning meeting. And today we have Dr. Sarav Shah to talk to us about surgical management of common lung diseases. Dr. Sarav Shah is an Baroda Medical College alum. He did his MS General Surgery from Baroda Medical College, and then he did his DNBSS chest surgery. And his training was at Sir Gangaram Hospital, New Delhi. Presently, he is working as Specialist Registrar, Center for Chest Surgery, Medanta, the Medicity, Gurgaon. So, Dr. Sarav, over to you now for 40 minutes or so, and then we'll have 10 minutes of discussion. So, over to you.
Thank you so much, sir. Thank you. So, good morning, everybody. So, this is going to be an interactive session in which I'm going to be sharing a couple of videos that I have on my screen, on my laptop, the routine surgeries that we perform and the different kinds of surgical diseases that we find in the chest. The thing that surprises me the most in India, especially, is the fact that there's not a lot of awareness of thoracic surgery. I'm sure you guys have heard of the branch cardiothoracic and vascular surgery, CTVS surgery, but hardly anybody knows that there is this branch called thoracic surgery, and we specialize only in lungs, the mediastinum, and the esophagus. We do not touch the heart. And mostly 90% of our surgeries is basically by minimal access, that is either by VATS or RATS. VATS is video assisted thoracoscopy, and RATS is robotic assisted thoracoscopy. So basically, I'm working at the Center of Chest Surgery. We are located in Medanta, the Medicity, Gurgaon, Haryana. I am now going to start my presentation, and I'll just tell you the scope of diseases that we cover and we perform in our routine practice. So basically, the VATS program that we offer, it covers diagnostic procedures. It treats the disease of the pleura. We cover pneumothorax and bullous lung diseases. There are a ton of cases of TB and its sequelae in India. This is of special interest to India and its patients. Anterior mediastinal pathology. Most commonly, you'll find thymomas over here, patients with myasthenia gravis and thymoma. A lot of people don't understand the importance of thymectomy in cases of myasthenia gravis, but it's a matter of very, very, very important discussion that needs to be addressed. There are a lot of trauma cases, hemothorax, pneumothorax, rib traumas, sternal fractures that we perform, we operate on, and there's always lung cancer and esophageal cancers, and even esophageal benign diseases that we operate on. So all of these diseases are covered by our VATS program. And I think 90%, as I earlier said, 90% of our surgeries are done by VATS or RATS, and 10% are done by the conventional thoracotomy. So first I come to the diseases that are prevalent in India and which need to be addressed, which a lot of people don't understand, know how to treat, how to refer, and where to refer. So this is the first case that I'll present to you. It's empyema thoracis. So what is empyema? Empyema is basically a collection of pus in the pleural cavity. It can be because of many causes, right? It can be after tuberculosis. It can be after a parapneumonic effusion. Parapneumonic effusion can be because of a bacterial disease, a viral disease, a fungal disease. A lot of causes for empyema thoracis. So what happens if a patient comes to you with empyema thoracis and you do not treat the patient? You just let the patient be treated, be managed conservatively. There will be fibrosis of the lung. Once the fibrosis sets in, there's no reversing of the disease. So the patient will have constant breathlessness. There is contraction of the thorax. The rib spaces reduce in size. This causes shrinking, like the patient will shrink to the other direction. So they'll have some cosmetic deformity. The empyema might drain into the plane of least resistance. It can be into the chest wall or it can be into the bronchus. If it drains into the chest wall, you have the empyema necessitans, and the patient will have a persistent sinus with a lot of foul smelling discharge coming out from his thoracic part. And the worst complications that we've seen is mediastinitis, osteomyelitis, the empyema going into the heart, through the pericardium, and even sepsis. So empyema, we have a patient over here who had cough for 1 year. His chest X-ray was done, which showed right pleural effusion. Multiple tappings were done. The tapping showed an exudative effusion with raised ADA. And the gene export study was negative, but since the ADA was raised, he was started on ATT with the diagnosis of pleural tuberculosis. The patient resolved, the symptoms reduced after starting the ATT, but then they recovered after 3 months, and then repeating, the tapping was repeated twice after that. He was later evaluated with a CT chest. I'm just going to show you the video of an empyema, the way it looks. Sorry. This is how the patient presented to us. He's got a loculated effusion. This is the pre-op CT scan where you see a loculated effusion over here. And the pleura is thickened. So we go into the pleural cavity. There are a lot of debris over here. All these are debris secondary to tuberculosis. A lot of adhesions, a lot of debris. We are first going to debride the cavity, remove all the debris inside, everything inside. All the flakes that you see, all the pus flakes, all the TB nodules that you see, we're going to remove them. We try to inflate the lung, but there is a thick peel over the lung that is not letting the lung expand. So now we are going to remove the visceral peel over the lung to help it expand. All the flakes that you see, all the pus flakes, all the TB nodules that you see, we're going to remove them. This is the lung over here, the lung, and this is the peel that is over the lung. This peel will not let the lung expand even if you remove all the debris and all the fluid inside. You'll have space issues. And then the patient will be on a prolonged ICD, and it'll be a troublesome matter for you. So this removal of this peel is extremely important and can be only done by surgery, either thoracotomy or VATS. Mobilizing the lung completely 360 degree, even from the pericardium. So after removal of visceral peel, the peel over the lung, we are now going to be removing the parietal peel. That is the pleural peel over the chest wall. There is mobilization of the diaphragm as well. We're removing the adhesions from the diaphragm as well. There's a thick peel over the diaphragm that is going to be removed. And now you'll see the beautiful lung expanding. Remember this image. Remember this image where you see the lung expanding completely. This is this immediate post-op X-ray. So I hope you remember the image that I asked you to remember, the one with the lung that is completely expanded. So what the principle of decortication that a lot of people don't understand is that the peel, the visceral peel of the lung, it has to be removed no matter what you do, no matter how you treat the patient. If you do not remove the visceral peel, things are not going to be better. This is the visceral peel that you see. This is the visceral peel that you see. This visceral peel, if you do not remove this, no matter how well you treat the patient, you inject streptokinase, you inject TPA, tissue plasminogen activator, you insert chest tubes, no matter what you do, the lung is not going to expand. This peel needs to be removed, and unless you do not remove this peel, the lung is not going to expand. So there are a lot of senior doctors over here. I actually wanted to know, I wanted a rough idea of how do you guys treat a patient who comes with you with pleural effusion? Anyone? I'll repeat the question. How do you guys treat a patient who comes to you with pleural effusion? Okay. So basically, so empyema, okay, let's go ahead with the treatment of empyema. So this is the wax decortication that you've seen over here, which needs to be done in all cases of empyema. All right, I've showed you the video. So now I'm just going to tell you how to proceed with a patient of empyema thoracis. So what are the indications of surgical intervention? So empyema can be divided into 3 stages. There's stage 1, the exudative phase, the stage 2, which is the fibrinopurulent phase, and the stage 3, which is the organizing phase. Stage 1 can be treated by chest tube insertion. Stage 2, the fibrinopurulent stage. In this stage, there's a lot of debate amongst pulmonologists and chest surgeons whether to treat the patient surgically or conservatively. The video that I've shown you before is a stage 2 empyema. The peel has already formed. In our experience, there is no way that you can treat the patient properly and completely without a surgical intervention. No matter how many injections of streptokinase you insert or how many tissue plasminogen activator, DNAs you give the patient IV or through the chest tube, it is not going to make a difference. If you do not remove the visceral peel, the lung is not going to expand. And when it doesn't expand, you're not going to have a complete surgery. Timing of surgery is another important question. When do you refer the patient for surgery? As I said, exudative phase, that is the phase 1. lasts for around 2 weeks. The patient can be treated conservatively with chest tube insertion with culture-based antibiotics, and you can wait and see if the patient resolves or not. When you have stage 2, that is when you start seeing some purulent material, or you see that you order a CT scan and there's multiple multiloculated effusions, or there are many septations. At that point of time, you send the patient to a thoracic surgeon. This is the easiest time for surgery, the quickest time for surgery, and the best time for surgery. This stage 2 will start from around 2 weeks to 6 weeks. After 6 weeks, you have stage 3, that is the organized empyema. In organized empyema, there's a thick peel, there's a thick parietal peel, a thick visceral peel. Decortication is essential. It is actually not essential. It's the only treatment in stage 3 empyema. But the thing is, the patient suffers. There's a lot of parenchymal injury. There's relatively a lot of blood loss, and the hospital stay of the patient increases. But you don't have any other option but to send the patient to a thoracic surgeon at stage 3. So I would say it's the best time to send a patient to a thoracic surgeon is between 2 weeks to 6 weeks of inserting an ICD. You insert an ICD on day 1, you wait for 2 weeks, you treat the patient with IV fluids, IV antibiotics according to sensitivity, and you repeat an X-ray, you repeat a CT scan after 2 weeks, you see that there's no improvement, send the patient to a thoracic surgeon, let him do an intervention. 2 to 6 weeks is the best time. Early intervention, early surgical intervention is better for the patient. There are a lot of patients who come to us after 6 weeks, and at that point of time, the chest cavity is contracted, the pleural peel is thick, the visceral peel is thick. It takes a lot of time, a lot of effort to perform the surgery, and there's a lot of discomfort for the patient. So again, a lot of pulmonologists will tell me that why can't we use streptokinase in stage 2 that is given in multiple textbooks? Again, streptokinase and tissue plasminogen activators. These are two things that in our experience do not work in patients of stage 2 empyema. Okay, stage 2 is fibrinopurulent empyema. There is loculations, there is septations, there is already a peel, a visceral peel over the lung, and streptokinase and tissue plasminogen activator do not work over there. They just make things even more difficult. Post-streptokinase cases, there are a lot of adhesions caused by the streptokinase itself that causes even more difficulty in our cases. So moving on from empyema, you have a patient who comes to you with pneumothorax. You see his X-ray, there is a collapsed lung, there is pneumothorax. What do you guys do? The first thing that you guys will do is insert a chest tube. So a chest tube is something that, in my personal opinion, even an intern doctor should know how to insert. It is one of those life-saving procedures that every medical doctor should know, starting from interns to physicians to surgeons to specialists. Pneumothorax ICD insertion is essential. And there's a different lecture that I'll take sometime in the future of safe ICD insertion that everybody should share and learn, because pneumothorax can cause death. If there's a tension pneumothorax, the patient can die if you don't intervene, like if there's no intervention in the next 5-10 minutes. So ICD insertion in cases of pneumothorax is very, very, very crucial, very basic, and it needs to be learned by everybody. We have a program called Safe ICD Insertion, and that program is actually aimed at interns, MBBS students, and even to some points, still to some extent, MDs and medical residents. I'll share that at some other time. So basically, in pneumothorax, you put an ICD, and then you wait for the pneumothorax to resolve, you wait for the lung to expand, and then if there's no air leak, what you'll do is you'll remove the tube. But what you need to understand is that you need to find the cause of the pneumothorax, right? If you do not find the cause of the pneumothorax, there is almost a 50 to 70% chance of recurrence. Pneumothorax, it can be because of bulla, a bleb, right? Bullas and blebs are small air pockets on the surface of the lung that keep on rupturing and keep on releasing air, and that causes a pneumothorax. So it can be because of a bulla, a bleb. It can be because of it can be secondary to COPD. It can be secondary to ILD patients because of the diseased lung. There are many causes of pneumothorax, which are caused by intrinsic lung diseases. There is also a rare entity called catamenial pneumothorax. This occurs, it is very, very underdiagnosed, and it usually occurs in menstruating women. So basically, when a woman menstruates, there is endometrial bleed. I'll touch the topic of catamenial pneumothorax later on, but basically pneumothorax, if you just insert a chest tube and let the patient be, and then remove the chest tube after the lung expands and the air leak stops, the pneumothorax is bound to recur because you're not treating the root cause of pneumothorax, right? So how do you proceed? If there's a bulla, a patient presents you with pneumothorax, you insert a chest tube, the lung expands, you do a CT scan, a CT chest, and there's a visible bulla or a bleb at the apex of the lung. That's the most common site for bullas. And there's a visible bulla or a bleb at the apex of the lung. How do you proceed with this patient? Like, you know that if the bulla or bleb is not treated, there's going to be a recurrence. The recurrence rates are as high as 50 to 70%, right? So this is what we are going to show you over here. We have a 15-year-old male patient who presented with complaint of breathlessness and left side chest pain. Chest X-ray was done. That was suggestive of a left pneumothorax. He was managed by a chest tube insertion, but the lung did not expand completely. Hence, we took up the patient for VATS. This is the lung after going inside the chest cavity. You see this over here. That's the bulla over here, right over here. This causes recurrent pneumothorax in almost 50 to 70% patients if not treated. So you take a stapling device, take a wedge of the lung, and you simply fire it. All done. This ensures that the pneumothorax won't recur. So basically, we are rubbing the chest wall to cause some inflammation. This inflammation will help us so that the lung, when expanded, will stick to the chest wall. This ensures that there is no recurrence of pneumothorax. You remove the diseased lung, that is the bleb over there at the apex of the lung, and then you just rub the pleural wall, the chest wall, causing inflammation, and making sure that the lung sticks to the chest wall. And if you make the lung stick to the chest wall, there is no space. The space is obliterated, and there is no pneumothorax. a very small procedure, uneventful procedure. Usually we don't find any complications in such patients. This patient was discharged on post-op 3. The patient starts having his normal meals on POD1 itself, 6 hours after surgery. The patient is walking, talking, mobile, and he's having his own meals. And he's discharged without any ice, without any chest tubes on POD3. So this is another example of multiple bullae that we see on entering the left pleural cavity. This is going to be a little complex case. Just bear with me. This person is a COPD patient, a chronic smoker, causing multiple bullas on his lung. Multiple large bullas. There's a big bulla over here. Bulla, multiple bullas. Oh, it's the entire, the entire left upper lobe is full of bullas. You rupture the bulla and you staple it. Staple all the bullas individually. All the bullas are individually fired and removed. Right. This is the final specimen. The amount, there's a big bulla over here, a second bulla over here, third bulla, a fourth bulla, a fifth bulla, multiple bullas in this patient. So you would ask me, why would I do this surgery in a patient of COPD or even in a case of ILD? So basically these bullas, they occupy a lot of space in the chest, right? Because they are huge. And these bullas are non-ventilating. They are not providing any ventilation to the patient. They are not helping the patient in any kind of manner. And the healthy lung is compressed by these bullous lesions. So if you remove these bullas, there's a chance that the healthy lung will expand. It will have more space to expand. And that causes an improvement in cases of COPD, in cases of ILD, where there are huge bullas occupying a lot of space in the hemithorax, right? So removing these bullas is going to be beneficial for the patient. You remove the bullas, make the healthy lung expand. It's good for the patient. So again, the last example of a chronic smoker. You see the diseased lung. It's all because of smoking. It's all because of smoking. The upper lobe is stuck, mobilizing the lung. Over here, you have the bulla. The entire thing is a bulla. Thanks to smoking, his lung is diseased and there's a bulla causing pneumothorax. If you do not remove this bulla, the patient will have recurrent pneumothorax. The entire specimen is being removed. Again, we are rubbing the pleural surface over the chest wall. That causes inflammation. And when the lung expands, it sticks to the chest wall, obliterating any space. Completely expanded lung. So now I'm going to move on 2 VATs in TB, and it's equally, right? So empyema is one of the cases that we've discussed before. TB, tuberculosis is rampant in India, and empyema is one of its biggest complications and one of the widest complications that we've seen. And we know how to manage it now, right? So what is the other complication that you frequently encounter in patients of tuberculosis? Fungal infections, aspergillus, mucormycosis, right? Especially these fungal infections have taken a mainstream role after COVID. You have a lot of cases of aspergillus infections, a lot of cases of mucormycosis, right? So basically, we are now going to be talking about aspergilloma and why does it need to be treated by a surgical hand. So aspergilloma is usually present in cavities that are preformed, like a tuberculous cavity that is preformed in a case of a patient with diabetes or immunocompromised because of any cause and has history of tuberculosis. You'll have aspergilloma in these patients, right? Aspergilloma is basically caused by Aspergillus fumigatus. It's a fungus, right? And it'll occupy the pre-existing cavity, causing an aspergilloma. Patients of aspergilloma will usually present to you with complaint of cough, hemoptysis. We'll also have complaints of breathlessness at times, chest pain. But most commonly that we've seen is that the patient usually present with complaint of with hemoptysis, right? So how do you treat a patient of aspergilloma? You give antifungals, correct? Correct. But what you should understand is, what you should understand is that aspergilloma cavities are not supplied by blood. There is no blood supply to the aspergilloma cavity. So no matter how many antifungals that you give the patient, the aspergilloma is not going to go away, correct? So you have diffuse aspergillosis in which the lung is completely, entirely affected by the aspergillus fungus. Pulmonary aspergillosis, then you have aspergilloma, which is a fungal ball. This aspergilloma cannot be treated only by antifungals. As I said earlier on, it is not supplied by any blood vessels. So no matter how many antifungals you give the patient, it is not going to affect, it is not going to reach the aspergilloma cavity, the fungal ball cavity. It is not going to reach over there. And unless the antifungals don't reach there, it's not going to resolve. The only treatment and the guidelines say that aspergilloma needs to be treated by surgery. It can be either a wedge resection, a segmentectomy, a lobectomy, but it needs surgical resection. There's no other way of treating an aspergilloma other than offering the patient surgery and then antifungals, right? So I'm going to show you a video of a wedge resection of aspergilloma. Since it is an inflammatory condition and an infective condition, there are going to be a lot of adhesions in the chest. So first, we are going to mobilize the lung completely. Sorry. Complete mobilization of the lung. This that you see over here, this structure over here, is the aspergilloma cavity. It's a huge aspergilloma. It's a huge fungal ball. We're just gonna wedge dissect it now. This entire thing that you see, the blackish part on the top of your screen, is an aspergilloma cavity. So we are simply gonna put in staplers and just resect it. A lot of people think that aspergilloma surgeries, fungal surgeries cause a lot of bleeding, a lot of diseases, a lot of complications, there's a lot of morbidity, a lot of mortality. That was true earlier on, but not in this era of fat surgery. You can see the amount of blood loss, it's minimal. There's hardly any blood loss over here. This particular patient did not receive a single unit of blood. Most of our aspergilloma patients either receive no blood transfusions or receive one at the most PRBC during the surgery. That is truly the beauty of VATS, right? It's minimal access, there's magnification of the view, no blood loss, things are under control. Fantastic. Just gonna remove the fungal ball. This is the aspergilloma, the whole fungal ball, the cavity, the fungus inside the cavity. You can see the fungus inside the cavity. This is not going to resolve with only antifungals. No way. You need to get this disease out of the body. If you do not do a source control, no matter how many antifungals you give, things are not going to resolve. You look at this thick cavity, there's no way an antifungal is going to penetrate this. No way. You need to offer the patient a surgical cure. This is the specimen, right? The specimen that I showed you in the video before. The cavity and the contents, the fungus, it looks ugly. So, as I said, there are a couple of misconceptions about aspergilloma surgery. Any fungal surgery, to be honest, even if it comes to muca, it comes to aspergilloma, people think that there's a lot of blood loss. Incorrect. Earlier on, when you did a thoracotomy, there was blood loss. When there were no stapling devices, there was blood loss. Correct. But nowadays, with the invention of endoscopic stapling devices, with VAT surgery, there's hardly any blood loss. I cannot express this deeply enough, but there's hardly any blood loss. Most of our patients do not receive any blood transfusions. And if there is some blood transfusions required, it's hardly even PRBC. That's it. Again, people think that there's high operative morbidity and mortality. Incorrect. That's absolutely incorrect. We have a case series of almost 60 to 70 patients. Till date, we've operated 60 to 70 patients of aspergilloma by VAT surgery. Our operative mortality is 0. The only morbidity that we find is in patients who have a lot of comorbidities, right? So in patients of diabetes, COPD, ILD, active tuberculosis, in these patients, we have some morbidity, and the morbidity is in sense of prolonged ICD. So when I say prolonged ICD, I mean that the patient is discharged from the hospital on post-op day 5 or 6, but he is discharged with a chest tube in situ, right? The patient goes home or he stays near the hospital with a chest tube in situ, and this chest tube is basically kept because there's some air leak. Because of some parenchymal injury during dissection, there is some air leak, and that causes the chest tube to stay a little longer. But even these chest tubes come out in like what, 2 weeks or so? So that is the only morbidity that we face in patients who have diabetes or active TB, or their lungs are bad, have COPD, ILD. Otherwise, these patients, most of our patients, healthy patients, fit patients without any other comorbidities, they are discharged without ICDs, with all the tubes out within 5 to 6 days. A lot of people also would like to, like they have a query about bronchial artery embolization, right? Most of these patients, aspergilloma patients, they'll present to you with complaint of hemoptysis. Hemoptysis can be an occasional hemoptysis, or it can be a massive hemoptysis, or massive episode of hemoptysis. Let's say 200 ml of blood that's the patient has just puked out. So what do you think the role of bronchial artery embolization is? So bronchial artery embolization is just a way to delay surgery, right? If a patient presents to you with a massive hemoptysis, you cannot just put the patient for surgery, because that is going to be troublesome. You cannot intubate a patient with active hemoptysis and plan him for surgery, like a planned procedure. That is going to be very troublesome. So in such cases, you offer the patient a bronchial artery embolization. It is just like a intermediate step. Bronchial artery embolization will help you to control the hemoptysis. After that, you send the patient to a thoracic surgeon, a chest surgeon for definitive procedure. A bronchial artery embolization is not going to be a permanent cure. The patient will have recurrence within 3 to 4 months. At the max, the patient is fine. It's for 6 months. 6 months, that's it. The patients have recurrence after that. Because these aspergilloma cavities, they increase in size, they erode the nearby tissue, nearby arteries by increasing in size, and they cause hemoptysis again and again. So unless you don't remove the cavity, things are not going to be fine. So this is an article that we've published, and it tells us about our experience in aspergilloma surgery, right? So we have operated almost, this was published, I think, back in 2019. After 2019, with the onset of COVID-19, we have operated another almost 30-40 patients of aspergilloma, 26 plus 15. So that's almost 40 patients, 41 patients, plus 20-30 patients, 70 or 80 odd patients. We have a publication coming out in December with a case study of 500 patients, right? In 2021, we have operated 500 patients, and we're going to make a study of that in December. I'll come back to you with that presentation in December itself. Once we've completed that presentation, 500 cases of all kinds of thoracic diseases, from lung cancers to pneumothorax to aspergillomas, a lot of surgeries in mucormycosis. Right now, there's a lot of surgeries going on in our department post-COVID mucormycosis because of high uses of steroids. Diabetes patients on steroids, they have a lot of mucormycosis, and we've been operating a lot of mucormycosis cases. So basically, the entire spectrum of thoracic surgery cases is 500 cases. We have 500 cases till now, and we're going to make a case study out of that. We're going to make an analysis of that, and we're going to come out with that analysis in December. So I think I'm running out of time. So I'm just going to show you, I'm going to give you a quick run through of the other things that we do. You have VATS in lung cancer. A lot of people say that you cannot do VATS in lung cancer because of lack of mediastinal lymph node dissection, because people say that if you do VATS in lung cancer, the surgeon will not be able to remove all the mediastinal lymph nodes. That is incorrect. With proper experience, with proper expertise, you can remove all the mediastinal lymph nodes along with the lung, along with the primary neoplasm, right? I'm just going to make you go through a quick video of our VATS surgery in lung cancer. Okay. This is the lesion in question. Exploring the pleural cavity. We are dissecting the IPL, the inferior pulmonary ligament. Yes, sir. Dissecting the hilum, the anterior hilum. We are going to bare all the vessels, stapling the superior pulmonary vein, some more dissection, looping the bronchus, stapling the bronchus. All this is done by VATS. The entire lobectomy is done by VATS. Again, hardly any blood loss. The patient did not require any transfusions. Looping via the superior pulmonary vein, firing the superior pulmonary vein. Right, taking the specimen out. Once the specimen is out, and now we are doing lymph node dissection, the mediastinal lymph node dissection. A lot of people think that this is not possible by VATS, and people the surgeons miss out on mediastinal lymph node. We are going to remove every single lymph node from all the stations. Just injecting the pulmonary cavity, ropivacaine for pain relief, complete expansion, lobectomy is done. The post-op X-ray, even after 6 weeks of surgery, you won't even know that this patient has undergone any kind of surgery, right? The lung is completely, the lower lobe has completely expanded, taken up the entire left hemithorax, right? There's hardly any scars. There are only 3 scars of 1 centimeter each. It's a beautiful way to perform surgery. Another example of VATS in intrapulmonary cyst. There's a cyst in question, going in through VATS, looking at the lung, dissecting the lung from all the chest, from all the adhesions with the chest wall. A lot of dissection. The cyst was in place since a very long time. That causes a lot of adhesions. Mobilization of the lung takes some time. Dissecting the cyst now, stapling the cyst. Basically, this is just another lobectomy. The patient had an intrapulmonary cyst in the lower lobe, and we are just going to do a lobectomy, right? That's one of the other aspects of VATS surgery. This is the of the cyst. This is what we removed. And this is the cyst. Entire procedure done by VATS. Post-op X-ray. Lastly, a lot of patients, I have seen a lot of mismanagement in cases of hydrated cyst, right? I don't know why, but hydrated cyst is complicated. We don't have simple hydrated cysts coming to us. They've been messed up by people beforehand, and then the patients come to us, and that causes a lot of issues. But hydrated cyst can be treated by VATS as well. Over here, you have a hydrated cyst. Dissecting the lung, mobilizing the lung. The cyst is over here. You could see the cyst. Dissecting it all over. Again, performing a lobectomy for the hydrated cyst in the left lower lobe, stapling the vessels, looping the vessels, stapling the vessels again. The surgery is almost done. Something went wrong. Just going to fire the bronchus now. Taking the specimen in an endo bag. Lung is expanding well. This is a specimen that we've taken out, the left lower lobe. This is the cyst cavity, the hydrated cyst cavity with a germinal layer. You can see the lung. The cyst cavity is completely filled up with the upper lobe. No issues whatsoever. That's it.
Thank you, Dr. Sarav. You can stop the screen sharing so we can have some discussion.
Sure, sir.
That was really beautiful. It was a kind of a pictorial journey. For a non-surgical person like me, it looked like I am going through a workshop on surgery because the things were so clearly seen when you are showing. I have a very basic question. You said it is minimal access surgery. Then how do you take out all these large masses, fungal balls and lobes, etc.? I mean, you may have to put a big incision to take them at least out.
No, sir. So basically, we create a working port. A working port is a 2 centimeter skin incision, and the pleura, we cut the pleura inside for at least 4 to 5 centimeter, and then we compress the mass and we take it out. Okay. So you take it in an endo bag. An endo bag is a rupture-free plastic container that squeezes the tissue inside, and then you just pull it out. It can be completely done by VATS. The maximum incision that we put is 2 to 3 centimeter. That's it.
Wonderful. So now the house is open for questions, comments. We see Dr. Manoj Yadav, pulmonologist. Manoj, any comments?
Yes, sir. Good morning, sir. Yeah, that was a really good presentation. And considering that cardiac surgery is now again starting, it is a boon for us pulmonologists. Otherwise, we hardly used to have any people operating on the thorax, doing lobectomies and pneumotomies. And that is why we used to use a lot of streptokinase. And I agree with him that we should send the patients complicated dural effusions for early surgery. And of course, aspergillomas also. Because we have seen patients bleed to death in cases of aspergilloma.
Thank you, Dr. Manoj.
Thank you so much, sir.
Any other comments, questions? So thank you, Sarav, for joining us. It was wonderful.
Thank you so much, sir.
And of course, we will have you again because it seems you have a lot of volume of work with you to share.
Definitely.
So we'll invite you again. Thank you for
so much,
joining
sir.
us. Thank you all.
Thank you, sir.
So now we will meet on 20th November. That will be, we are skipping 2 Saturdays for Diwali vacation, as many of our members may be traveling. So usually we skip 2 Saturdays during Diwali festivals. So thank you all. We'll meet again and wish you all a very happy Diwali and prosperous New Year. Thank you. Bye.